Welcome to our monthly series of community health talks on Asian health. My name is Bryant Lin, and I'm the co-director of the Center for Asian Health Research and Education here at Stanford. This series is brought to you by the Center, CARE for short, as well as the Stanford Health Library. Great thanks for joining us today. Today we have the great pleasure of welcoming Dr. Andrew Lee to talk about understanding gastric cancer and its relationship to the immune system and microenvironment. Dr. Lee is a fellow in the Division of Gastroenterology and Hepatology at the Stanford University School of Medicine. His research interests are in gastrointestinal cancers, precision medicine, and therapeutic endoscopic procedures. Welcome, Dr. Lee.
Thank you for the introduction. And thank you to Stanford Center for Asian Health Research and Education and the Stanford Health Library for this opportunity as well. Today, we'll be talking about gastric cancer and the immune system, an important area of research, and hopefully we can learn some things together. So in terms of topics we'll discuss today, we'll start with an overview of gastric cancer from its presentation to diagnosis and some overview of its management before talking about the development of gastric cancer. How does it start with inflammation and turn into cancer over years to decades. We'll then talk about the role of the immune system in its process and how this ties into some of our current areas of research. So let's start with gastric cancer. Before diving into that, we should talk a little bit about the normal stomach. The stomach is, as most of you know, a vital digestive organ. Its primary role is in digestion, and it does so through the chemical breakdown of food, as well as enzymatic digestion with proteases. To do so, it has a variety of specialized cells, including parietal cells, chief cells, among others. Shown here is kind of a cartoon version of the stomach. The stomach has a couple of different regions. Near where the esophagus, that's sort of the food pipe, connects into the stomach, is the cardia. Then is the body of the stomach, and finally the antrum. And after the antrum is the small intestine. The anatomy of the stomach is important, as different types of gastric cancer have a predisposition for different areas of the stomach. Shown here are some endoscopic images, which are images obtained during endoscopy, which is essentially a kind of flexible camera that can be inserted through the mouth into the stomach. And you can see kind of the corresponding parts as shown in this cartoon here. There are a couple different types of gastric cancer. Today we'll be talking primarily about adenocarcinomas. Those are the most common type. Adenocarcinomas span these three types here: the blue, the orange, and the gray. And they're kind of broken down into these different types based on both their location, whether it's near the gastroesophageal junction or elsewhere, as well as some molecular features. But the type we'll be speaking primarily about is the intestinal type here, and that's because it's both the type of gastric cancer that causes the majority of cases, but also because it has precursor lesions, and that's kind of really the area where we think there's the greatest potential to make an impact. Aside from adenocarcinomas, there's a couple less common types, including stromal tumors, including sarcomas, as well as lymphomas, and very rarely neuroendocrine cancers. So what does gastric cancer look like? It can have a variety of different appearances, and here are kind of two I suppose stereotypical cartoons for how it might look. As shown here, it can occur in different parts of the stomach, and they can have different appearances. On the left is more of what we would call a polypoid appearance, and there's an endoscopic image that correlates to that. Or sometimes it can be kind of an ulcerating appearance, as shown on the right. Why is gastric cancer important? Well, worldwide, it's the fifth most common cancer and the third most deadly cancer. The incidence of gastric cancer in the United States is a bit lower, but still quite substantial, about 28,000 cases a year in the United States and 11,000 deaths. And within the United States, there is a disproportionate burden of disease on Asian Americans. And being a Stanford CARE talk, I thought I should mention this. But as you can see here, the incidence of gastric cancer in Asian Americans is higher than in all races and compared to non-Hispanic whites. Within Asian Americans, Korean Americans are at the highest risk, followed by Japanese Americans, Vietnamese Americans, and Chinese Americans. How does gastric cancer present? The thing I want to emphasize here is that gastric cancer is usually asymptomatic in its early stages, meaning that they don't have symptoms, and that usually by the time symptoms occur, it's at a later stage. And most of these symptoms are kind of can be attributed to later stages. For example, abdominal pain or unplanned weight loss, both suggest perhaps a later stage. Nausea and vomiting can occur if there's kind of mass effect, causing difficulty in the stomach emptying its contents. Gastric cancer can manifest as gastrointestinal bleeding, which would appear as black stools, as when there's an upper GI bleed and it passes through the digestive tract and is digested, the color changes to black. Rarely it can cause difficulty swallowing if it's located near that gastroesophageal junction. And finally, anemia related to slow chronic blood loss. Gastric cancer can be diagnosed through a variety of ways. It may be picked up incidentally on imaging, or if imaging is obtained specifically due to concern for gastric cancer. Historically, upper GI series were used. This is kind of a series of X-rays where you drink a contrast agent and you take pictures as the contrast moves through. That's not used as much these days. Instead, the most common imaging modality is probably a CAT scan. And as shown in the picture here, you might be able to appreciate the stomach. I'm outlining here, and you see there's kind of this thick area here compared to the rest of the stomach wall. And this thickened area represents a gastric cancer. So this would be a concerning imaging finding, but that alone doesn't cinch the diagnosis of gastric cancer. To do so, usually biopsies need to be obtained, and gastric cancer, like most other cancers, is diagnosed on the basis of pathology. So the way this is usually collected is through an endoscopy, as illustrated in this cartoon here, where a flexible scope is inserted into the stomach, and through the scope, multiple instruments can be used to obtain biopsies that are then looked at under the microscope by pathologists. The vast majority of cases, 90% of diagnoses are made this way, and kind of that small minority of cases where diagnoses are made otherwise are usually when biopsies are obtained from elsewhere if the cancer is spread elsewhere and they suggest a gastric source. Other information is usually needed to complete a staging workup, and by staging, that usually means determining how far the cancer is invaded, has it spread to other structures, and the couple of tools here combined with the imaging and endoscopy that we've just discussed are endoscopic ultrasound, which can provide you up to sub-millimeter resolution of how deeply a cancer is invaded. So as shown in this cartoon here, you have this kind of cancerous growth here, and shown from left to right are cancers that have invaded more deeply. And as they invade more deeply into the stomach wall or even adjacent structures, that means that it's a higher stage. Sometimes a diagnostic laparoscopy is used too. So this would be a surgical procedure in which cameras are inserted into the stomach to see if there are cancerous masses or collections that have spread outside the stomach. And during this process, as well as with endoscopic ultrasound, you can assess the neighboring lymph nodes. This is somewhat of a busy slide, giving kind of a 10,000 overview look at the treatment of gastric cancer. But the takeaway that I want to communicate here is that as you go from earlier stages to more advanced stages, so up here is kind of early stages, there's an option for endoscopic resection as defined as denoted by ER or surgery, which offer the potential for cure. In local regional disease, surgery is an option with or without chemotherapy, depending on if it's surgically resectable. But as it gets more advanced, whether it's metastatic or more advanced local regional disease, at some point it becomes not surgically resectable. And at that point, options would be chemotherapy. But these chemotherapy regimens at that point are not for curative intent, but rather to prolong life with the best quality of life possible. So this is to say, like most cancers, the sooner you catch it, the higher chance of cure you have and the better outcomes you have. So with that, I'd like to segue into how gastric cancer develops and the role for screening. So we can start with what are the risk factors for gastric cancer. This is a table taken from an article published in 2016 that shows a couple different risk factors associated with gastric cancer. And you'll see that these risks differ between non-cardiac cancer and cardiac cancer, and this refers to where in the stomach it occurs. We're primarily talking about today is the non-cardiac cancers, and you'll see that most of these things are environmental factors, but the ones that have the highest risk are going to be H. pylori infection, and we'll talk a little bit more in depth about what H. pylori is, but that gives a relative risk of 3 times compared to those without H. pylori. Other things that are associated with gastric cancer include things like cigarette smoking, excessive alcohol consumption, but you'll see that risk is really much smaller compared to H. pylori. Other things, obesity, a family history of gastric cancer, high salt intake are also associated. And finally, there's this entity that we'll spend the next couple of slides discussing called gastric intestinal metaplasia. It's what's called a precursor lesion. And you'll see that once gastric intestinal metaplasia develops, the risk of gastric cancer is more than 6 times higher. Vegetables and fruit are shown here in that studies have shown that they have somewhat of a protective effect. And so patients who eat more vegetables and fruit have a lower risk of gastric cancer in population studies. So what is H. pylori? H. pylori is a bacteria. It's in fact classified by the World Health Organization as a group 1 carcinogen. And that really reflects that it's the most important risk factor for gastric cancer that we know of. It's a very common bacteria, and in fact, about half the world's population has H. pylori. But clearly, half the world's population does not have gastric cancer. In fact, only a small subset of those with H. pylori go on to develop it, at most about 2 to 5%. And the incidence of gastric cancer varies very widely by up to about 10-fold. And so what this implies is that there is likely other factors responsible for this difference in gastric cancer, even despite H. pylori, and those are going to be things like genetic factors, environmental factors like the ones we just discussed, or things related to the bacteria itself. There are different strains of the H. pylori, which have different proteins that they can express and affect the gastric cancer risk. So how does gastric cancer actually develop from H. pylori infection? Well, there's this entity called the Correa Cascade that was described about more than 20 years ago that essentially lays out that with chronic inflammation, whether it's from H. pylori or in other forms of inflammation such as autoimmune gastritis, you can form chronic gastritis. And over time, a subset of patients with chronic gastritis, meaning chronic inflammation of the stomach, can have atrophy of the stomach, where the stomach loses some of its specialized cells. In addition to losing the specialized cells, when you look endoscopically, it'll look like it's lost some of its usual features. And once that develops, it's called atrophic gastritis. Once atrophic gastritis develops, this is considered a precursor lesion, meaning that it's been shown to be a significant factor for risk for gastric cancer. A subset of patients with atrophic gastritis over years to decades can develop gastric intestinal metaplasia. And what metaplasia means is the replacement of one mature cell type with another. And so in this case, it means that intestinal cell types start appearing in the stomach. And the reason this happens is felt to most likely be kind of a reflexive healing response by the body. It's kind of dealing with chronic inflammation and the damage that creates in response. some cells adapt and take on this intestinal type, some intestinal type features. Once gastric intestinal metaplasia develops, that's the precursor lesion we talked about previously that has this greater than 6-fold risk for developing gastric cancer. A subset of those folks will develop dysplasia and eventually cancer. So once we have these precursor lesions, the reason we care about them is that we know patients with these lesions are going to be at high risk of gastric cancer. And so maybe this is an opportunity to intervene and survey these patients more closely and catch gastric cancer in its early stages, or maybe even prevent its development by taking out, for example, areas of dysplasia. So that's, I think, a natural transition into talking about gastric cancer prevention and screening. As we've kind of alluded to a little bit earlier, there's wide variation in screening strategies in the world, and that's mostly dependent on how common gastric cancer is in different countries. So in areas of the world where gastric cancer is much more common, such as East Asia, some countries such as Japan and Korea have adopted universal screening programs. And what that looks like is starting at age 40 or 50, patients, everyone in the nation is recommended to get an upper endoscopy or a barium radiograph in Japan about every 2 to 3 years. Other nations where gastric cancer is not as common, and that includes the United States, the formal guidelines are to screen a little bit more selectively, just those with increased risk of gastric cancer, whether that's the precursor lesions we discussed, inherited disorders, or who have a family history. And like we talked about before, the screening options would include things like endoscopy. That's, again, taking the camera to look closely at the surface of the stomach and look for some of these subtle precursor lesions, or sometimes contrast radiography. However, this is not used as commonly anymore, in part because it has pretty low comparatively lower sensitivity for early gastric cancer, and it essentially cannot be used to see a gastric intestinal metaplasia or chronic gastritis or atrophic gastritis. In terms of H. pylori, as we talked about, it's the most important cause of gastric cancer. And so a natural question is, well, is there a role for eradicating or treating H. pylori? The short answer is yes, there is. In nations that have a high rate of gastric cancer, there are data to say that treating gastric cancer reduces the risk, treating H. pylori reduces the risk of gastric cancer down the line. In areas such as the United States, there aren't really guidelines to screen universally for it. It's more so based on symptoms, or if someone is felt to have kind of a higher risk. The one caveat I'd give here is that there is this kind of notion of the point of no return, in that once gastric intestinal metaplasia has developed, treating H. pylori, depending on the study you look at, does not decrease the risk of going on to develop gastric cancer, meaning that you want to really treat H. pylori before that gastric intestinal metaplasia has developed. So we've talked a little bit about the different screening approaches in different parts of the world and the United States. And what I'm showing here is some data comparing when gastric cancer is diagnosed in South Korea, Japan, and the United States. And I just want to draw your attention to 2 lines here. So this first line here is when gastric cancer is diagnosed at a localized stage. So that would be an early stage of gastric cancer. And you'll see in South Korea and Japan, around 50% of the time, gastric cancer is caught at an early stage. In comparison, in the United States, it's at a later stage. Only 28% is caught at a localized, and a higher proportion is at a more advanced stage. And this is likely reflective of different screening practices that we've discussed. What goes along with that is the 5-year survival. So in South Korea and Japan, The 5-year survival of patients with gastric cancer is 65 to 67%. In the United States, it's less than half that at 32%. And again, this can likely be attributed to a lack of earlier detection. This is some more data kind of further supporting that. So in Korea, the national screening program with endoscopy every 2 years was introduced in 2001. And since then, the 5-year survival rate has gone from something roughly comparable to the US, I mean, a bit higher, 31 in the United States versus in the 40s in Korea. But you can see since that was introduced, that 5-year survival rate has really increased over time, up to 75%. Again, further building on this, shown in this chart is the percentage of gastric cancers over time that are detected at early stages. And you'll see that, again, since 2001, since screening was introduced in South Korea, the percent of early gastric cancers has gone up from, at diagnosis has gone up from about the low 40s to now 70%, whereas in the United States, where we have no such similar program, it's remained fairly constant in the low to mid 20s. Finally, this is a different way to kind of look at this data, which is in patients who've had multiple endoscopies, and this is data out of Korea, compared to patients who've never had endoscopy before, the odds of dying of gastric cancer related mortality are shown here. So in patients who've had one endoscopy, the odds are about 40% less. If they've had 2 endoscopies in their lifetime, about 70% less, and more than 3 times, it's almost 80% less. And so I think all of these taken together really show the role for screening endoscopy in kind of a higher risk population as in East Asia. And when you combine that with the comparatively higher incidence of gastric cancer in Asian Americans compared to the general American public, this kind of really gets at the topic we want to address, which is how to detect gastric cancer earlier stages and better serve these higher risk populations. So the precursor lesions that we talked about before, just to kind of give you an idea of the risk of progression to gastric cancer. So shown here are 4 different lines. And as we move from the bottom to the top, we start with atrophic gastritis. That's, again, when you've had chronic inflammation for a while and you lost some of the usual features of the stomach. Over time, maybe about 1% of patients with atrophic gastritis go on to develop cancer. Once intestinal metaplasia is developed, there's about a 2% chance can go on to develop gastric cancer. And of patients who have dysplasia, where you kind of had these abnormal looking cells, but that are not frankly cancerous yet, that rate is much higher. In low-grade dysplasia, it's less than 5%, but once you get more severe dysplasia, that risk is substantially higher in the 30s. So how does the immune system play into gastric cancer and its development? Well, gastric cancer is not unique in this regard, in that inflammation and immune system play a role. In fact, it's, I think, fairly widely accepted at this point that chronic inflammation is kind of a hallmark of many types of cancer. About 25% of cancers have at least some underlying chronic inflammation associated with it, whether that's due to microbial infections, autoimmunity, or some type of dysregulation. And to give you kind of more concrete examples, things like cervical cancer and human papillomavirus. HPV causes about 90% of cervical cancer. In gastroenterology, another cancer that has an association with chronic inflammation would be inflammatory bowel disease and colon cancer. Patients who have diseases like ulcerative colitis or Crohn's disease have a much higher risk of colon cancer. Gastric cancer is no exception here. So chronic inflammation, whether from H. pylori or autoimmune gastritis, over time causes changes that predispose towards the development of cancer. Other things like tobacco and obesity can tie into this chart here. So tobacco and obesity are both thought to cause some low-grade inflammation, which can cause an increased risk of cancer. And What we're really getting at here is that inflammation over time can be a risk factor. And the reason for that is inflammation is associated with production of free radicals, which can in turn cause DNA damage and increased cell turnover. And anytime you have increased cell turnover, every time a cell divides, it introduces the possibility for mutations to occur. And those mutations have the potential to lead to cancer-causing mutations. Finally, once cancer has occurred, even if inflammation was not necessarily part of the development of its cancer, there's in most cancers some degree of chronic inflammation. To maintain kind of the environment in which the cancer can live, the certain kind of immune cells are recruited. Some of them are anti-inflammatory cells that tell the immune system to not attack it. Other times they recruit immune cells, which through kind of a combination of cytokines and other signaling just help produce an environment in which the cancer can thrive. Before we delve too much further into it, I think we should talk about very briefly the immune system. I think an in-depth view of the immune system is probably beyond the scope of this talk, but in order to kind of talk about its relation to gastric cancer, we have to at least discuss a couple of things here. So from a 10,000 foot view, the immune system has kind of two main arms: innate immunity and adaptive immunity. Innate immunity is kind of an immediate and non-specific response to microbes or other kind of insults to the body, and it comprises things like the skin, but also things called phagocytes, and those might be things like neutrophils or macrophages, which kind of eat microbes. Dendritic cells are cells that can present these antigens and signal to other cells. And finally, natural killer cells. As you can see here, the innate immunity system works fairly quickly, on the order of about hours to a few days before the adaptive immunity system kicks in. And that's comprised primarily of B cells and T cells. B cells are the cells that are involved in production of antibodies. And so, for example, when a vaccine is given, you're training the B cells to form these antibodies. And that's called a humoral immune response. There's another component called a cell-mediated immune response, and that's driven primarily by this population cell called T lymphocytes, or T cells. And these cells learn to specifically recognize antigens that microbes may present, or in the case of cancer, antigens that are kind of more specific to the cancer itself. So with that background, we can talk about how the immune system ties into H. pylori infection, the development of gastric cancer. What I want to try to demonstrate here is that H. pylori, being a bacteria that causes an infection, does induce a very strong immune response, and a lot of immune cells are recruited in. But despite that, almost uniformly, gastric patients and the immune system do not clear the infection. So this happens through a variety of ways. As shown here, some specific immune cells are recruited here between macrophages, T regulatory cells, which are kind of an inhibitory cell that tamp down the immune system, and dendritic cells, and it creates this type of environment in which H. pylori can continue to live and not be eliminated by the immune system. It does so by modulating the innate and adaptive immune response through these type of cells here, in the cytokines or kind of signaling molecules that they secrete to create a somewhat immunosuppressed environment locally at that level. In addition, as shown here, the bacteria itself has a couple of factors called virulence factors, which are proteins that the bacteria secretes that can recruit different cells through a variety of mechanisms. And while the details of this slide are probably a little beyond the scope of this talk, what I kind of want to show here is that proteins that it can express, such as this cytotoxin associated gene A and VAC-A here, which is vacuolating toxin A, they have effect on populations such as macrophages here, neutrophils here, dendritic cells, and those in turn secrete molecules that recruit or regulate other types of cell populations, for example, the T cells and natural killer cells that we've mentioned before. As you progress further along the development of gastric cancer, there's kind of further changes that occur. And this is summarizing kind of decades of work into one slide. But again, what I want to kind of emphasize here is that there's a diverse set of immune cells that are recruited into that local environment that interact with each other. Those are kind of instrumental into both the initiation and progression of gastric cancer. Some specific things that studies have described are altered balances of specific types of macrophages, and as we'll discuss a little bit more, the expression of something called PDL1, which is a programmed cell death ligand 1, which is kind of a don't attack me or don't eat me signal that can be expressed as you get kind of these precancerous changes. And then once cancer develops, a fair amount of gastric cancers express this PDL1 molecule along with further changes in the microenvironment that allow it to escape immune surveillance. So once gastric cancer has developed, several changes kind of take effect to maintain its environment and for it to evade detection and attack by the immune system. Just highlighting a couple of things here. Macrophages change their kind of signaling and receptor profile into one that's not as associated with kind of recognition of the gastric cancer and attacking the gastric cancer. They, through a variety of kind of signaling events, also cause dendritic cells to decrease the tumor antigen presentation. And by doing so, the immune system is not able to recognize it as well. And finally, as shown here, the PDL1 molecule I mentioned before, the kind of don't eat me signal, is upregulated in some gastric cancers, which enable it to escape attack by the immune system, and specifically T lymphocytes and natural killer cells. And so there's really this complex interaction of these different cell types that work together to form the cellular milieu in which a gastric cancer can kind of continue to survive and escape immune surveillance. And this is actually an area in which cancer researchers have investigated and developed some treatments. And so these two drugs here, nivolumab and pembrolizumab, are drugs that inhibit this PDL1 system, and in doing so enable the immune system to sort of directly attack the tumor. And this is what's referred to when patients get immunotherapy, and is in fact now kind of used in both first line treatment for gastric cancer, as well as second and later lines of therapy as well. Ipilimumab is a drug that will activate T cells, again, to kind of rev up the immune response as an anti-cancer treatment. And finally, there's a new therapy in the works of CAR T therapy. This is an exciting new therapy. It's primarily still in clinical trials, but I thought I would mention it because it really involves utilizing the immune system and its machinery as an anti-cancer treatment. And essentially what they do in this treatment is they collect your own T cells, and they insert a gene into the T cell that contains a receptor that can recognize the cancer cells. They then grow this in a petri dish, if you will, before infusing it back into the patient. And then within the patient, these T cells can recognize the gastric cancer cells and attack them. The last thing I'd like to mention in terms of the local microenvironment beyond the immune system is really the role of the microbiome. Included in the microbiome is primarily bacteria, yeast, and viruses. Most studies have focused primarily on bacteria, as that's kind of the easiest to study. And again, H. pylori, which we've talked extensively about today, is a bacteria. And so this is kind of one of the classical examples of the microenvironment leading to other diseases in the form of gastritis and eventually gastric cancer. However, there is some work that suggests that there are alterations in the microbiome that extend beyond H. pylori. So is kind of illustrated in this figure here. There's been a couple of papers in the recent years that have suggested that as H. pylori infection progresses, there is decreased microbial diversity, as well as this phenomenon known as dysbiosis, both functionally and in terms of the expected kind of structure and diversity of the microbial environment. And that may in turn lead to increased inflammation or carcinogenesis directly, or there's some other theories that this may be through kind of metabolites that the bacteria produce. And so, for example, what that might mean is, things that you eat are metabolized back by the bacteria into some substances that may be harmful. And so there's a lot of interesting work right now in this field looking at how the microbiome interacts with here, although the one caveat I'd say is that none of these things have kind of been conclusively shown to be associated with gastric cancer, aside from H. pylori, but this is still kind of a very early field, and there may be things to come. So I just want to transition at this point into talking about how this relates to our research and give a slight plug to it. So right now we're doing work sponsored by the Stanford Center for Asian Health Research and Education on identifying the role of cellular neighborhoods in the development of gastric intestinal metaplasia and gastric cancer. And as we've really seen through the past half hour or so, the immune system and gastric cancer are kind of intimately related in the development from chronic gastritis to gastric intestinal metaplasia and eventually gastric cancer. But there's really been very few studies that looked very systematically and broadly at the different cell types involved. There's been targeted studies looking at specific cell populations and genes, but the couple studies in the past couple of years have taken this more unbiased approach. But the downside of the approach that's used in this specific methodology is that you kind of lose the spatial resolution. And as you might gather, one of the things we really care about is kind of the cell-to-cell communication, as each immune cell relies heavily on the signals it receives from neighboring cells to kind of determine how they act and kind of the environment that's created. So really what we are working towards now is trying to identify the kind of tissue architecture themes and pathways that are involved in the progression of chronic gastritis to intestinal metaplasia to gastric cancer, both to identify them as areas for future research, but also so that we can maybe develop a better risk stratification model for gastric intestinal metaplasia. As I mentioned before, about 2% of gastric intestinal metaplasia goes on to develop gastric cancer. So if there's a way to better risk stratify those who are at higher risk and maybe need more closer follow-up versus those who are lower risk and maybe don't even need follow-up at all, that would be helpful. So to do so, we use this technology called Codex, which is shown here in kind of this colorful picture here. It's a technology that allows us to look at very high spatial resolution individual cells and all the different immune markers that they might express, or cell signaling molecules, or some gastric cancer or intestinal metaplasia specific markers. And we can get this very high resolution, in-depth look at how these cells interact with each other in these different disease states as you progress from a normal healthy stomach to gastrointestinal metaplasia and so forth. So in conclusion, gastric cancer is a significant cause of morbidity and mortality worldwide, including in the United States, disproportionately on Asian Americans. It has a precancerous progression, and there's a role for screening in certain high-risk populations to try to either catch gastric cancer in its early stages, or if there is an advanced precursor lesion, maybe even prevent gastric cancer. And finally, I hope I've impressed upon you that the immune system likely plays a key role in the development of gastric cancer through chronic inflammation, starting usually with H. pylori, but also through other causes. But really the mechanisms underlying this aren't really well understood. We know a lot about what certain cell types are involved, what signals are involved, but kind of the finer details of how it actually progresses over time is still really an active area of investigation, and hopefully more to come on that. So I'd like to acknowledge a couple of people, my mentors within the GI division, Drs. Rogala, Dr. Huang, and Dr. Huang, for helping me work on this project, but also being kind of experts in this field. In fact, I'll point the audience to Dr. Zhuhao Huang's talk in this forum from March of this year, also on gastric cancer. And finally, of course, the Stanford Center for Asian Health and Research and Education. And I'll take any questions.
Great, thank you so much, Dr. Lee. What a fantastic, fascinating talk. So first question, are stomach warts, flat warts, I assume they're flat polyps, maybe they're referring to, dangerous and a precursor to cancer? And how do these come about and how do we prevent them?
I think it probably depends on what we mean by warts. If they were all benign and you weren't recommended any follow-up, they may be something benign like a fundus gland polyp, which don't have any precancerous potential. But if there's something like an adenoma, then that could be a precursor to cancer. But if you were advised that they were all benign, my guess is it wasn't one of these precursor lesions. But I'd probably have to go back and refer to the gastroenterologist and pathology reports about what these warts were.
Great. Yes, it's very important what the details are. From another viewer, is it possible to have intestinal metaplasia only without atrophic gastritis? Is atrophic gastritis in a later stage than intestinal metaplasia?
That's a great question. So the kind of classic pathway that we discuss is that you start with chronic gastritis, and then the subset develops atrophic gastritis, and then intestinal metaplasia. But it's certainly impossible to just have an intestinal metaplasia without atrophic gastritis. Atrophic gastritis is felt to be probably, a quote unquote earlier stage in intestinal metaplasia. But sometimes you can develop gastric cancer without necessarily having intestinal metaplasia as an intermediate. But this kind of progression to Correa Cascade is kind of just the classic progression. But yes, you can have intestinal metaplasia even without atrophic gastritis. And though, we mentioned that most of these are caused by H. pylori, another kind of related and common question that we get is, why do I have this if I don't have H. pylori? What the biopsies tell you at that time is really that you don't have H. pylori currently. It's quite possible you may have had H. pylori in the past, and it just happened to be treated perhaps inadvertently. Maybe you received antibiotics for some other cause, and it happened to treat the H. pylori.
Great. Next, we've got a lot of questions heading up. Next question, not quite sure I understand, but perhaps I'll paraphrase. Is the inflammation-inducing mechanism, are the inflammation-inducing mechanisms in gastric cancer the same as in esophageal cancer, as like with reflux? Are there similar mechanisms there, or are they're different?
So that's a great question. The short answer is it's different. So in the esophagus, the most common risk factor there is uncontrolled GERD or gastroesophageal reflux disease, where you kind of have acid going up the esophagus. The stomach itself is the organ that produces the acid, and so the stomach is kind of adapted to this acid environment already. And so the cause of the inflammation is different in that in the esophagus, the cause of the inflammation itself is really the acid exposure, whereas in the stomach, the most common cause, like as we discussed, is H. pylori. That said, in the esophagus, the precancerous lesion called Barrett's esophagus is a form of intestinal metaplasia, but the biology is a little bit different. The interesting thing about gastric cancer and esophageal cancer is that some of the gastroesophageal cancers, so gastric cancers that occur near that junction of the esophagus and the stomach, tend to behave a little bit more like esophageal cancers, and that's why they're kind of separated out in that regard.
Great. I'm going to combine a couple of the next questions from June Kim and Cindy Lajowski. They're asking about why do certain groups, Koreans, Japanese, Chinese, have higher rates of gastric cancer? Is it related to diet, genetics, environment, and why is it higher perhaps in Asian countries as opposed to Asians in the US?
Great question. So I think a lot of the risk is probably just directly related to how common H. pylori is. H. pylori is much more common in East Asia than it is in the United States. And that alone, I think, explains a lot of it. But there's probably definitely a degree of environmental and genetics there. One of the interesting things is if you look at people who've immigrated to the United States from East Asia, in that first generation of immigrants, the risk of gastric cancer is basically the same as it is in Korea, Japan, or China, where they're from. But within 1 or 2 generations after that, that risk basically becomes that of the general American public. And so that speaks to kind of the environmental component. And that environmental component, again, would include H. pylori, but also things like diet. That said, there probably is a genetic component as well. There are certain genetic disorders associated with it, but in terms of more common genetic things, I think it's not as well understood.
Great, fantastic response. Another question relates directly to your talk and Dr. Huang's work. Is there a screening recommendation for endoscopy, for upper endoscopy in the US, like colonoscopy?
So generally, no, unless you fall into a high-risk group like family history. Part of the difficulty here is with insurance coverage because saying you're, for example, of East Asian descent, technically from an insurance perspective, doesn't qualify you for a screening endoscopy unless it's, you're saying there's some associated symptoms. And so part of what Dr. Huang has discussed previously here, and part of his work along with Robert Huang, is kind of this push to have these guidelines modified accordingly based on what we know. And essentially, I think what we're trying to say is that if you're high risk, meaning first or second generation immigrant from a high incidence region, or there's a family history of gastric cancer, it's reasonable to do an endoscopy at age 50. But some of the difficulty, like I said, is with insurance coverage. If it's for screening, there may not be a copay. Whereas if it's symptomatic, then there may be a copay. But if insurance doesn't think there's an indication for screening based on kind of the usual US guidelines, then you may be stuck a little bit unless you have symptoms. But that said, most people have had some sort of abdominal upper GI symptom at some point.
Great. The other question is, are there any genetic tests for propensity for gastric cancer?
There are not any available. That's definitely an area of active investigation in kind of this whole field of biomarker discovery to try to, identify less invasive tests or methods for diagnosing gastric cancer or those at higher risk of gastric cancer. It's an active area of investigation, but there's really nothing that's ready for prime time yet.
Great. And then from Christina Louis, what is the likelihood of having a recurrence of gastric cancer, specifically if diagnosed and treated successfully? What is continued screening is recommended for a gastric cancer survivor?
Great question. So the recurrence of, there always is a risk of recurrence for gastric cancer, and it kind of depends on how early it was diagnosed and what kind of treatment there was. If it's completely resected and they felt like they got good surgical margins and it hasn't spread anywhere, that risk is going to be lower than if there were, for example, positive margins. There is this interesting notion of what's called a kind of metachronous or synchronous gastric cancer, where patients can have a second gastric cancer develop at a different site or even at the same time as the same gastric cancer. And there's some studies that show that H. pylori treatment, even after a gastric cancer is resected, does decrease the risk of a later gastric cancer. And so that kind of does bring into question the kind of this notion of the point of no return I spoke about before. But the screening interval will kind of depend on, again, how confident they are that they got good margins.
Related to that question, next two questions, I'll combine them, are about immunotherapy for gastric cancer. How effective are treatments that utilize the immune system? Do they shrink the existing cancer cells? Are they effective? Will other chemotherapy be necessary? And then, kind of as an adjunct to that, are they prescribing CAR T for gastric cancer now?
Got it. So the immunotherapy that I discussed before, pembrolizumab, nivolumab, ipilimumab, it's usually used in combination with, quote unquote, conventional chemotherapy as kind of the initial treatment for gastric cancer, whether it's neoadjuvant chemotherapy or the initial upfront chemotherapy. It sometimes is used by itself after that, but it's not necessarily a replacement per se. And the studies that looked at it, the best outcomes were using that in combination with some type of conventional cytotoxic chemotherapy. In terms of the CAR T therapy, that's still very much kind of an investigational thing. It's in clinical trials, and there may be some that have shown some promise, but it's still in the kind of the clinical trial phase at this point.
Great, thank you. And then going back to prevention, I'm going to combine two questions from Adrian Arima and Eileen Yang. Is intestinal metaplasia reversible? And Adrian asks, is there a treatment for metaplasia to prevent it from proceeding to cancer?
Excellent question. So what studies have shown is that certainly in kind of more severe intestinal metaplasia, treating the H. pylori does not cause it to regress. It's a little bit debatable, but if you have early intestinal metaplasia, that can regress. If you don't have gastric intestinal metaplasia yet and just atrophic gastritis, that can regress with treatment of H. pylori. But let's say you have more moderate severe gastric intestinal metaplasia, there's really no treatment that'll completely reverse that. But once we know it exists, if you have other factors that might make you higher risk, whether it's kind of the distribution of the metaplasia itself or family history, we know to keep a closer eye in terms of endoscopic surveillance. So, it could be as frequent as every 1 to 2 years.
Great. And last question from Usman Ahmad. Do you have any thoughts on the inverse risk of esophageal adenocarcinoma and H. pylori?
That's a very interesting question. So there is this described phenomenon that as the risk of H. pylori and esophageal cancer are somewhat kind of inversely related. I don't know too much about the exact molecular mechanisms in terms of the in-depth explanation, but part of what H. pylori does is that it does decrease kind of the acidic environment, meaning that less acid is produced. And so if we think back to one of the main risk factors for esophageal cancer being reflux, if it's perhaps less acidic environment, that could be related. But I am not personally as familiar with the esophageal cancer biology.
Great. Actually, one more question popped up. Would you recommend Asian Americans get an upper endoscopy every 2 to 3 years for the 50+ age group, similar to South Korea and Japan?
Great question. And that's actually exactly what we recommend. So we typically say, if you're a first or second generation immigrant from a high incidence region, it's probably a reasonable thing to follow the guidelines from the country from which you immigrated. So for example, if you immigrate from Japan or South Korea, you might follow their guidelines. And so what that would look like might be an endoscopy starting at age 50, and depending on the presence or absence of atrophic gastritis or intestinal metaplasia, an endoscopy every 1 to 3 years thereafter. But again, it kind of depends on if you have intestinal metaplasia or not. Let's say you have that endoscopy and there's no gastric intestinal metaplasia, then you need to be surveyed less frequently. Potentially even may not even need follow-up if you don't have other risk factors like H. pylori or family history. Whereas if you do have it, it could be as frequent as every 1 to 2 years.
Great, fantastic. Well, we have a very sophisticated audience today asking really great questions. I know that Dr. Huang, the two Dr. Huangs, are really working hard to get coverage for screening endoscopies so that we don't have to, indicate a symptom-based diagnosis for screening in upper endoscopies. We really support their efforts to do this, and really great thanks, Dr. Lee, for your fantastic talk today. Welcome to all of you, and we will have another talk in November, so please join us. Dr. Linda Ging will be speaking about improving the diagnosis of underrecognized and rare diseases in Asians. Really look forward to you joining us then. Thank you for your attention tonight. Bye-bye.